teach and practice. Well, I'd like to welcome you all as well. It's good to be here with you in Portland. I haven't been outside today, but I looked out my window and I didn't see anything. So I think we're in a foggy day here. And welcome to all of you who are here by webcast. We've got some other folks that are joining us that are not in the room. And I think there's a little bit of a ring on the mic, but we'll get that cleared up. Okay. So I have a few questions for you, and I'll tell you a little bit about myself before we begin. So to start here, I am Dr. Arielle Schwartz. I live in Boulder, Colorado, and I think Boulder has a kind of similar feeling to Portland, except minus the fog. And I'm a clinical psychologist, and I have a private practice in addition to being a teacher. And I used to teach. I moved to Boulder originally to attend Naropa University, which is a small Buddhist university. They have a specialized graduate program in body-centered psychotherapy. And I attended that in 1996 to 99 at a time when somatic psychology was very fringe and kind of unheard of. And people said, is it semantic psychology? What is it that you're going out there to study? And but I fell in love with Boulder, and I fell in love with the study of how do we integrate the body into psychotherapy. And so I've stayed out there and continued in that realm for the last 20 years. And I went back to school to get my doctorate in clinical psychology at Fielding Graduate University here on the West Coast. It's out of Santa Barbara. And wanted to do my doctoral studies on the integration of mind-body therapies and to take a deeper dive looking at that from a more kind of scholarly angle, because Naropa was a very practice-based experiential learning model. And so I come from those two lenses. Also, as a kind of body-centered practitioner myself, I teach and practice yoga as well as kind of trauma-focused yoga recovery. And also, I think just something else that I'll mention about myself is that I'm an outdoorsy person. I probably have a lot of like-minded people out in Portland as well, and so I spend a lot of time hiking and being outdoors, and it's a major kind of resilience factor for me, and I like to take pictures of the outdoors, so some of those weave their way into these slides. So, I started out in the body-centered arena, started working with trauma, and pretty quickly started to hit walls of burnout in my own experience as a practitioner, and came to kind of realize, thankfully, early on in my career that I wanted to take a closer look at how do we create sustainable lifestyle for ourselves as therapists and practitioners, as well as for our clients, because I didn't want to burn out. I wanted to be able to stay working with clients who've experienced trauma without traumatizing myself in the process. So I call my work resilience-informed therapy, and there will be a lot of that woven into our talk about how do we work with complex PTSD or repeated developmental long-term exposure to traumatic events in childhood. So, that said, let me just turn this over to the room for a moment and just find out kind of who already focuses your work on clients who experience trauma. I figured that would be most of the people in the room, most of you. And not a surprise, because I think that the more that we put the lens on of looking at our history taking and looking at our clients' case conceptualization through inquiry about traumatic life events, the more that we see it, right? And I'm curious kind of what modalities people are using in the room. Who considers yourself kind of CBT? Yeah, okay, lots. And how about relationally focused? Great. And how about anyone already working with the body, already working with somatic psychology? A few of you, good. All right, and how about EMDR? Any EMDR practitioners in the room? Great. So what we're going to, how about DBT? I'll ask one more. Super. Okay. So we have a smattering of hands for all of these modalities. What we're going to play with here for the next 2 days is really how do we integrate across these modalities. Because the truth is when we're working with clients who've experienced childhood trauma, they need a lot of different ways in and ways to make connection. Most definitely they need a clinician who's willing to work relationally. If we come in with a series of tools and strategies and they're going to kind of sniff us out and they're going to sniff out whether we're authentic in ourselves, right? And because that's what they've learned how to do to survive. And so we want to honor that and not dismiss that. And so we want to be able to kind of come as a whole person meeting a person and find a way to do that that respects our own boundaries simultaneously and theirs. So in this integrative approach and a resilience-focused approach, we're also going to talk about positive psychology, Martin Seligman's work, and also a kind of biopsychosocial integrative piece so that we're not just talking about the mind and the emotions, but really the whole embodied experience of the impact of early trauma on health. So it's just a very broad statement overview, and we'll do some diving in here together. What I want to just name here, this is really about the scope of practice, that because we're covering a lot of different modalities across these 2 days, you are really responsible for recognizing when you need to get more support or more training to integrate some of these practices that you might be learning if you're not trained in EMDR. Even though we'll be speaking about that here, for example, you won't necessarily be ready to go out there and do EMDR with your clients, but you will have tools to be able to integrate in. And also, I just want to say that I do my very best to stay current with research and to understand. I'm not a researcher myself, but I'm kind of a nerd in that way. I really like to understand the brain. I really like to understand modalities that work. I'm a scholar practitioner, so I will integrate those. And as I mentioned already, we are looking at a rather integrative approach over these next 2 days. So we're going to just start out by defining what is complex PTSD, and to also just look at how this is differentiated from traditional PTSD and from other diagnoses as well. So when someone has experienced a traumatic event, a single traumatic event, they might come into our office with an experience of acute traumatic stress, right? Oh yeah, I got to get used to the airplanes going overhead. I had this moment of going, is it a tornado? What's that sound out there? Okay, airplanes. So in a way it's a good example because we hear something and we have to orient towards it, right? Yeah, so if you experience something traumatic, there's that moment of orienting to what just happened and how do I make sense of that in my world? And so someone comes in and they've experienced a traumatic event, they're in the process of trying to make sense of what just happened. And it's really normal to have a lot of big experiences after this. This is something that I really appreciate about Martin Seligman's work in understanding the curve of resilience and the curve of accommodating traumatic events, is that if we don't understand that feeling shaky or panicked or crying a lot is normal after trauma exposure, then we start to go, oh no, I'm going down. I'm going to develop PTSD because I'm having those experiences. So more and more, when we can normalize that actually having a big experience after something that was abnormal, something that was unusual, something that was quite frightening, terrorizing, right? I'll give an example. I had a client that came in, and I had already worked with her before. In fact, we had worked on some of her childhood trauma, but she had come in after witnessing a shooting. She was on her way to work in Denver, and there was a shooting that had happened from the car in front of her, out of the car. And it was terrifying. And she was shaking by the time she got to work. She had to leave work early. She came into my office about 2 days later, and she said, I didn't want to drive to work the next day. I wanted to take a different route. I didn't want to go down that same street. And of course, right? And so rather than pathologizing that response, rather than shutting down the emotions that were happening, we actually held space, and she shook in my office, and she let herself cry, and she told me about how frightening that was. And she called me up the next day, and she said, I was okay. I was okay. I was able to go back to work. Now, again, single incident. She witnessed something, but it didn't happen to her. She had already done some of her own work on trauma, so she understood the pathway. And there's some really beautiful research out there that says that when we have done some of our trauma work, we're actually more resilient when something else happens. We actually understand how to come through that. So we make space for that in our work. And of course, not everybody gets the support that's needed to work through traumatic events. And that's when we start to see the enduring effects of post-traumatic stress. And here, really, again, I want to emphasize that this is about not having the resources to process the trauma that leads to the overwhelm and the shutting down of processing, right? And so many of the individuals with complex PTSD, with childhood trauma, they have not had the support. They've not had the resilience factors in their lives, right? And this is where we're starting to see the intrusive memories, sensations, avoidance of reminders of the trauma, negative emotional reactions, whether this was recent event, whether it was from a long time ago. And now we'll take a look at the complex PTSD. And this is what we're really here to speak about. So this is where we are looking at repeated, prolonged exposure to traumatic events. And it's often, but not always, with childhood onset, although I will say that for the next 2 days, that is primarily what we're going to be looking at. And so we can see here abuse and neglect and disrupted attachment falls into this category, domestic violence, ongoing social stress, bullying. Something that I don't have in that category, but I'll name here, is the ongoing experience of an undiagnosed learning disability in school and the impact that that has on sense of self over time. Community and political violence that's experienced over time. And prolonged captivity or confinement, either in childhood or truly at any time in one's life, would lead to the development of complex PTSD. So some of these are very overt, objectively terrifying experiences. We also want to name that some of the kind of causes of complex PTSD can be much more subtle or invisible, right? In the case of childhood neglect, if we put on the lens, if we're doing our trauma history taking and we're looking for an event that we consider this was the traumatic event, and we're not pausing to look for the omission of something, right, then we might miss it. So neglect is in some cases more severe than early abuse. The lack of touch, the physical neglect, the lack of emotional attunement, the emotional neglect. And I think other pieces that we'll also just name at this stage is that what can impact the disrupted attachment can also sometimes be just real poor fit. For example, you get a highly sensitive child and parents who do not understand the inner workings or do not take the time to understand the inner experience of the child. So that chronic experience of being chronically misunderstood, right, can be well-intentioned external environment that's missing the mark consistently, right? And you know, I think we have a lot of different names for that kind of experience, but to hold it in the lens of a complex trauma adds an element to it. It's not always necessary, but I think what it speaks to is that a lot of what we'll be talking about over today and tomorrow can be applied in those situations as well. So I want to give an example here as well. This is a adult man in his 70s, and he had grown up in a large city, had grown up with parents who had both survived the Holocaust, and his father had lost his whole family. Upon coming to the U.S., had been a medical doctor in Italy and had no right to practice here in the U.S. And so also upon immigration, lost his standing, his ability to work. And eventually his parents got a divorce. His mother, who had also not lost her family to death, but had disconnected from them upon coming to the States, had gone into a depression. And so he had his external means taken care of, right? He had a home. He had two parents who were no longer married, but both cared for him in the best way that they could, and they were both severely impacted by their loss. His mother had severe depression. His father had severe PTSD. And after the divorce, his mother had worked outside of the home, and one of the kind of lodging, most challenging aspects for this client was the experience of being left outside of the house. And we'll get cell phones. That's just, thank you. It's just a reminder for everyone else. So. He was left out of the house for extended periods of time because his mother worked, and when he got out of school around age 8 to 10, he would be walking the streets between 3 o'clock and 5:30 when Mom got home. So for these 2.5 hours, was actually quite terrified. One of the questions that I asked him once was, well, did your mom know? Did your mom know that it was terribly frightening? Did she ever ask, how was that for you? Your inner world, your inner experience to be walking the streets for 2.5 hours. He just looked at me stunned, right? She never asked. And so even though nothing externally bad, he was not mugged, nothing terrible happened to him out on the street, he was terrified. Right? And he walked back and forth, and that was what was stuck inside of him, is this repeated experience of walking the streets. Right? So we put on, anyone in here familiar with Donald Meichenbaum's work? Yeah. And so we put on what he calls the Columbo hat, right? And he's so brilliant at really asking us to look with kind of detective minds and understanding not only what might be the contributing factors to someone's experience of difficulty or trauma or challenge in the world, but also we put on that hat to understand where is their resilience? How have they survived that so far? What has allowed them to overcome adversity up to this point, even though they might be in the hospital, suicidal, struggling with depression every day? Even though those symptoms might be there, we still want to look for what has helped them survive to this point. I will name here that I have kind of built-in times for questions, so I'll speak for a little while and then we'll break and we'll have some opportunities for questions. So if you've got them in mind, you can write them down, and you can either use this mic here or you can just speak them out and I'll repeat them because we've got people listening from home or from work. So we'll speak here about diagnostic clarification. So there is construct validity of complex PTSD that is distinguishable from PTSD and from borderline personality disorder. There is a lot of crossover. For those of you that are already wondering how are these symptoms going to look different from BPD, there's a lot of crossover. Sometimes it's both, and sometimes it's not, which is also important. And we'll also note that there's empirical evidence for the distinction of complex PTSD from PTSD in a clinical sample of children and adolescents. And there's also what marks this distinction is elevated disturbance in self-organization, interpersonal problems, and emotional dysregulation. So those are the three categories of symptoms that sit on top of avoidance symptoms and intrusive or re-experiencing symptoms that are more classic with your traditional PTSD. In the DSM-5, which I actually learned recently is not a Roman numeral because they realized that if we keep going down the I must have changed it up there, but not in the slide below. But anyhow, as we go forward into DSM 6 and 7, they realize that we can't keep having the Roman numerals or it's just going to get too long. So I learned why they switched it from the Roman numeral. Anyhow, CPTSD is not included yet in the DSM. There's been a committee, a long-term committee that's been arguing for the inclusion of CPTSD and disorder of extreme stress not otherwise specified. And what we do know is that the World Health Organization has included it now for classification in the ICD-11, and that is going to be coming out with its own codification in the next few years. So it's kind of moving forward in its depth of understanding. And as mentioned, we'll be talking about differential diagnosis here. So the accurate diagnosis can be difficult because our symptoms of complex PTSD are not only similar, but can be confused or comorbid with other disorders. And so when we have clients that are coming in with major depressive disorder or bipolar disorder or generalized anxiety, and I won't read these all because you have them on your slide, I actually think we still want to pause and stop and step back and take a really good trauma history. Because often these other presentations can be trauma-driven, can be trauma-derived. And we want to understand how all of this is interconnected. Like learning disabilities, for example, someone who experienced childhood trauma is at greater risk for developing a learning disability, and is also, there's a bidirectional piece, and I have this again later, but there's a bidirectional piece where someone with a learning disability is harder to parent. Right? There's greater dysregulation with a child that has ADHD, and that can start by the age of 2, where there is impulsivity and there's hyperactivity, and a parent who's not understanding that, and so those repeated complex dynamics can build into cycles. And so we want to, again, kind of be detectives here in understanding what might be going on in addition to major depressive disorder and so forth. We will talk some about conversion disorders where symptoms are primarily somaticized, and also about dissociation and the continuum of dissociation, which I'm seeing some nods in the room like, oh good, we need to speak about this. Okay, great. And I will speak again about a brief example here. This is a woman who was diagnosed with bipolar when she was in college, and she had very intense emotions that would come forward, a lot of impulse control challenges, a lot of rage that she would experience as a teenager, and she had also developed a eating disorder around that same time. And so by the time she came into my office, she was actually referred by her psychiatrist, who we cross-refer a lot, and she had recently moved to Boulder, and she had gone to see him, and he took a look and he said, you know, I think there's trauma underneath here. I'd like you to see my colleague. And so he refers her over. She at that point was in her 50s and had been on bipolar medication for over 30 years. And nobody in the 30 years of her medication management and in her therapy had actually ever taken the time to say, let's look at the trauma that's underneath this. You guys relate to this? Have you received clients' referrals? You're nodding. Yeah. And so we started to do a trauma history and, figured out that her father would rage, her mother had very poor boundaries, a lot of complex family dynamics, one of 5 children, so this feeling of not enough, insufficient attention in the home, having to vie for attention. She learned very young that really no matter what she did, nothing good was coming her way, and so she learned to pretend and to kind of put on an act in order to get by. And she had lived much of her life and have stuck in this place of not feeling authentic and not really feeling like she could be loved just to be her. And I think the other piece that can happen when you have someone that has lived underneath a diagnosis for so long, not that the bipolar was totally inaccurate, I think that there were elements of it that were true, but the part that was so painful about it is that within the family system, she identified, not just was identified as the sick one, she identified as the sick one. To be in that role actually ended up being the only way to get the attention that she so badly needed. And so part of what we have had to work through in her healing process is actually to recognize the role of being the sick one as distinct from who I really am. And to be willing to start to see herself outside of that. And so we actually have stopped using bipolar as her defining diagnosis, and she has tapered off the majority of her medications and learned that actually her emotions are valid. So we're working our way through it, but it's a pretty profound gift to walk alongside someone through that journey and to help them reclaim a sense of self beyond roles and diagnoses and terms, right? So let's see. We're perfect. So let's look at some of the contributing factors to the development of complex PTSD. And we're going to break down each of these across the next slide, so this is really just an overview here. The first of these is intensity, duration, and timing. So complex PTSD is associated with longer duration, right? Not a surprise. There's some research out there about kind of critical zones or critical periods when we are most susceptible, when children are most susceptible to traumatic exposure. Certainly the first 3 years of life, there is so much growth that's happening, and we're so vulnerable, we're so completely dependent upon our caregivers that if there is neglect or if there is abuse, not only are we rather helpless to do anything about it, but that helplessness can then be conditioned. This is something that Marty Seligman had started his work studying, was learned helplessness, and understanding how when an infant is being abused or mistreated or neglected, that they cannot escape, they cannot fight back, right? And that if that occurs over time, it becomes an identity of self. That learned helplessness gets so ingrained into the somatic experience of the self in the world, right? That then even when something happens at a time period in which maybe you could defend yourself or run away or go get help, right? That learned helplessness takes over because it's a form of memory. And so therefore, we're not going out and seeking maybe something else then happens in adolescence. But what's the point? Nothing ever works. Is a layer that's underneath that, right? I couldn't do anything about it then, so maybe I still can't do anything about it. And so when, how many people in here work with children? Great. And how many work with adolescents? Fantastic, a lot of the same hands. that is so fantastic to be able to get in there and help someone early on start to experience what help looks like, right? What care looks like. Do you all feel pretty lucky that you get to go in there and work with kids? Does it break your heart sometimes? Yeah. I think I work with the whole range. So I work with children and adolescents, basically from age 3 and up. I find it, I don't have quite the capacity to work under age 3, but I think that feeling of wanting to go in there and to feel like you're making a difference. And I think sometimes with children, it's very hard to get that feedback that what you're doing is making a difference, especially if they're pretty well defended. So just to know in yourself that you're making a difference, that early intervention is so key. And you become a resilience factor for that child as they grow up, hopefully, right? They let you be that. And adolescence is another critical growth period. Sometimes people refer to adolescence as the time period where all of the attachment dynamics come back forward and we either have an opportunity to heal them or repeat them. There may be some truth to that. I think that we continue to either repeat or heal attachment dynamics throughout our lifespan. So, but adolescents, especially as they're forming identity and going through hormonal changes, becomes another kind of key period. And it also is another rocky period within the family where, maybe during, I'll borrow a Freudian term, during latency, there was this kind of like, oh, it's okay for a little while, and then adolescence hits, and you're like, whoa, puberty, and there's all the rocky emotions and all of the reactivity that can happen in the home, and so another time where there's greater susceptibility. And so we'll look at another factor here, which is epigenetics and in utero influence. And this is based on the work of Rachel Yehuda, and she is a trauma and recovery researcher based out of New York. And she has done most of her research after 9/11, trying to understand the impact of trauma on women who were pregnant during 9/11. And she's also done a huge amount of her research tracking third generation, second generation, fourth generation Holocaust families, and understanding the impact of trauma across generations. So some of her conclusions, one is that there is a difference in the impact of a mother who has unresolved PTSD versus a father who has unresolved PTSD. And this is a really important piece because it speaks to the layer of this which might be epigenetic, not just learned behavioral exchange, but a biologically based exchange. So a mother that has unresolved PTSD is associated with a child's greater risk of developing PTSD after trauma exposure. And her understanding is that because the mother's cortisols have changed, her biology has changed, that it's actually predisposing the infant to some of those biological marker changes in how they're processing cortisol. And we'll look at that a little bit more closely as we get into the neurobiology of this. And so to distinguish that from having a father with unresolved PTSD, it puts a child at greater risk of depression. And here what we're looking at is that the impact of the parenting, the impact of the relationship certainly can have a long-term influence, but there's less of that biological shaping that is influencing how we're processing stress. So here's a little bit more about this. The infants who were born to mothers who were diagnosed with PTSD during pregnancy, so this was after 9/11, these infants were born with lower birth rate, they were harder to soothe, they were more prone to colic, right? Yeah. And anyone parents in the room? I like to know who's here. That's hard. That's really hard to nurture, or to feel like every time you go in to hug your child, they're arching your back away from you. And especially if you're also dealing with your own post-traumatic stress and then getting that feedback from your child. Okay? So the epigenetic changes are happen in how the body's responding to cortisol, and that can be passed across generations. I'll give a little kind of hint about this now, but we'll take a closer look as we go, that what she was looking at is the receptor sites for cortisol on the cell, and that there's changes at the cellular level in terms of how we're processing that, and that's going to be tracked across generations. It's fascinating and frightening. And it doesn't mean that you're doomed at that point. I think knowing one's own susceptibility and actually, again, looking at this from a resilience lens is really important. So along these same lines, we also recognize that disruptions in early attachment is a contributing factor to the development of complex PTSD. So this is a behavioral lens that we're looking at now. And here, mothers with post-traumatic stress are more likely to be both overprotective and reactive to their children. Right? So I think that's such a key piece, that not only am I, and in fact this is seen as in animals as well as humans. So if we look at it in rats for a moment, that the rats will go over and actually lick their pups more, right? And they will also, I don't really know what the reactivity looks like in a rat, but I think that over caring behavior becomes this compulsion that's biologically driven, right? And so to be overprotective of your child, but simultaneously more reactive to them, and how that might impact attachment. Right? And we look at, and we're going to go more deeply into this as we go throughout the weekend, but we look at some of the core attachment injuries, that the avoidant attachment leads to being more highly self-reliant and closed off emotionally. Ambivalent attachment, being highly reliant upon others for your regulation. And disorganized attachment, having difficulty trusting others, difficulty self-soothing, and this push-pull dynamic that again we might see with borderline personality. And while complex PTSD, depending on the kind of trauma, I think is often going to be linked to disorganized attachment, it's not always, right? So to really know the full lens here, and to understand that neglect might lead there to be more of an avoidant attachment style, and that some of that overprotective but reactive would lead to more of an ambivalent style, and ongoing repeated trauma where there's no escape can lead to more of the disorganized style. And we'll explore that more as we go. One of the strongest ways that transgenerational transmission, in addition to epigenetics, but the transgenerational transmission of trauma occurs is through early attachment. So here, early attachment communications, we recognize that they're primarily nonverbal, right? Yes, there's like coups that happen between the parent and the infant, but a lot of it is the quality of the touch, the quality of the eye contact, the quality of the attunement to, are you cold, are you hot, what's your body language, do you need to have your diaper changed, all of these exchanges. And Alan Shore, in his work on affect regulation and the self, is looking at the nonverbal exchange between the parent and the infant as this kind of co-regulation dance in which they're both informing each other, right? And so, the infant might make a sound and the parent goes, oh, and then the infant goes, ah, and the parent goes, woo, and they get excited, and then the infant turns away and the parent kind of settles, right? And there's this dance that happens in that exchange that has these bursts and then then return, where there's that excitement and the settling, the cortisol lifts and then it settles. And so some cortisol actually lets us play as well. Cortisol is not an all bad thing. And what we recognize about parents who have trauma is that they're missing those cues, or they don't let them stop. So for example, in that normal rhythm of the excitement phase into the settling phase, there's a point at which the excitement phase happens, the infant cues that they need to disengage, and the parent goes, come back, right? I'm not ready to stop playing. And so they override a boundary right there. The other piece about this really early exchange that happens is that children, infants, are primarily right-brained, right? They're primarily attuning to the facial expressions, the emotion, what's happening, what are you feeling. They're not putting this into left brain words. This is a felt gestalt experience. And so the work of Ed Tronick and his studying of the infant-mother exchange is that what he looked at with these kind of microsecond filming of the infant and the mother, and what he saw is that if the mother might be overall, like if you watch it in real time, the mother's smiling, right? But if you break it down to microsecond viewing, what you see are these little grimaces, these little moments in which the mother's face looks angry, right? And what you also observe is that the infant is mirroring those micro expressions. They're picking up on all of the, I'll use the word unconscious, unrealized emotions of the parent. And this research was mostly done with mother-infant, and particularly trying to understand the impact of depressed mothers on their infants. And so that the experience or the imprinting of the unexpressed or unrealized emotions that are happening in those micro expressions, the way that I like to think about it is that the shadow of what the parent is feeling is what the child starts to take over. And as a child grows and can accommodate more verbalization, more mentalization, to borrow from Peter Fonagy's work, I'm putting a lot of names out there. They're in your references at the end of your handouts, right? So Peter Fonagy takes a look at what happens as the infant grows and is able to internalize more mentalization, more words into toddlerhood, into early childhood. And so there is this profound experience when a parent says, gosh, I was really afraid when that happened. And the whole, like, the child goes like, oh my gosh, thank you, right? Like, it feels congruent. It feels true. I'll share a story here. A friend of mine who is a grandfather, his grandson came up to him and he said, Grandpa, why are you so angry? And he says, I'm not angry. And his grandson says, well, tell that to your face. And so, like, kids are so great because they're just going to say it if they feel safe, if they feel comfortable, which clearly he did. And he went like, oh, wow, you're right. Maybe I am. And so, I now have a 15 and 13-year-old at home. And I'll tell you, there is no, faster path to self-awareness than no, that's not true. There's plenty of fast paths to self-awareness, but that's certainly a fast one. And so long as we're willing to receive the gift of that mirroring, of that feedback, because actually that is part of the exchange. Like, yes, we want to take care of our children, and we don't want them to be our caregivers and take care of us, but when they're picking up on something, when they're saying, hey mom, you're looking really angry right now, and if we deny that, we're actually denying their gift, right? And so that's part of the pain of this complex repeated developmental quote-unquote trauma, is that the gift of the child often is never received. who they are, what they perceive, how they experience you as a parent or the family or what it is that they want gets denied, gets pathologized. They get taken to the doctor because they're the one acting out rather than, I'll share one more story here. So again, I mentioned I work with all ages. So this is a 8-year-old boy that was brought to my office a few years ago, and he is brought in because he's having behavioral problems, and he's getting angry a lot and having a lot of impulsivity and so forth. And so he gets brought in, and he is sitting between mom and dad on the couch, and so I said, well, what brings you all here? Why are you here? It's our very first session, and mom says, well, little Joey's been having a lot of anger, and it's really disrupting our home. And little Joey turns to them and he goes, and you. I just cracked up. As I can work with this kid. Right? And what was beautiful about this family, and Ron, I'm getting a little bit of ringing again on the mic, so I don't know if that's something we can do something about. But anyway, what was beautiful about it is that the parents laughed. They didn't get angry back. They didn't deny it. They both just nodded and they said, yeah, this is really a family thing. I said, great, we can work with this. Yeah. Had they turned bright red, which they might have done that too, and then denied it and said that's part of the problem, we would have had a lot of harder time working together, right? And that's happened too. So another factor in the development of complex PTSD is the poor modeling of health behaviors. So just keeping track of okay, we're doing good. Growing up in a home where medical care was not consistent, wasn't provided, wasn't available, insufficient modeling of one's own hygiene or self-care. A gal that came to me and she said, nobody ever told me that I was supposed to wear deodorant. And I was in middle school and I was made fun of and I didn't even know that I was smelling. Lack of encouragement of health-promoting behaviors such as exercise, healthy eating, and also excessive modeling of high-risk behaviors, smoking, substance abuse, etc. Right. Same gal, the one that I was just describing, also described growing up in a home where there were a lot of unhealthy people that were going in and out of the home, and how terribly frightening that was, people coming in, doing drugs. No sense of that even was not normal, because when you're growing up in a household and that's your experience, It's often not until later that one goes to somebody else's house or grows up and realizes, well, gosh, everyone else's home, people weren't doing drugs in your house, right? And so having those reference points, and also for those of you working with children and adolescents, recognizing that that's all that's known, right? I'm just going to name here, I see several of you getting up, getting coffee, whatever you need. I like that. That's a good thing. I think that 2 days of sitting in a room without windows can feel a little confining. I don't want this weekend, or it always feels like a weekend, this 2 days, to be traumatizing. So please take care of yourself, and if that means getting up and stretching, and if you need a break before we take a break, I don't take offense. I just know you're taking care of yourself. Let's see. So the fifth factor is the presence of a learning disability. I spoke about this a little bit earlier, and what we know here is that about 35% of individuals with dyslexia report abuse before the age of 18. And as I mentioned before, this is a bidirectional correlation. Right? So that individuals who have learning disabilities are both more likely to develop a learning disability because of growing up in a household where there was abuse or neglect, right? Because that's changing how the brain develops in those early phases of development, that critical growth period. And children with learning disabilities are just flat out harder to parent. I say that from experience. So, it's, you know, it takes more work. It takes more of a village. It takes a lot of grounding and depth of understanding. And when you're growing up with that kind of struggle in a household where parents either don't get it, it's not diagnosed accurately, it's the child's coming home and they're feeling stupid, or they start acting out as soon as they get home from school, or they're acting out at school, and so forth. So it becomes a vicious cycle. Okay? And there are also social and cultural factors, and this is, I think, ever true. It's very amplified in our world right now. The experience of oppression, prejudice, ongoing discrimination can lead individuals to feel isolated, excluded, bullied, harassed. And we all may be working with clients who experience chronic stress of uncertainty, the fear of the threat of deportation, poverty, disability, right? This is a very big topic right now, and it would be remiss to exclude that from this conversation this weekend. It's been interesting to give talks across the country. So in the last month, I've been on a kind of interesting tour across the country speaking, and I was in Atlanta, in New York, in Colorado, and here, and then I'll be in California in a few weeks. And it's fascinating to have this conversation in different parts of the country. I'll say that in doing the PESI talk in New York, there in Manhattan, it was just so rich, and I'll be curious to have some of these conversations with all of you as well, to explore who was in the room and who was treating whom, right? That there were individuals that said, well, I work primarily with Caribbean immigrants, right? Or I work solely with HIV survivors, or I work with, so forth. And so that cultural conversation and the impact of cultural identity is a very integral part of all of this. And the demographics of the individuals that you work with and their experience of belonging, right? Just a core sense of belonging to their community, whether their family has a sense of belonging. So another layer to this. And the lack of resilience factors, right? So this is our seventh major contributing factor, and that what we do know is that having a single adult who takes interest and positive value of a child in their world makes a difference. Right? That's the initial research by a man named Norman Garmese, who was looking at the impact of children growing up in poverty, and this research has been taken in many different directions. And so what we look at now is the protective factors that surround the child who's experiencing abuse or neglect in their home. And what we recognize is that being involved in activities, having a teacher, a coach, a neighbor, a therapist who takes interest and care in the inner life of that child is willing to step forward and to protect or to stand up for, all of that makes a difference, right? And when the resilience factors are lacking, the experience of neglect and abuse can be amplified. So trauma is about the vulnerability of the individual, not just the event. I'm going to pause here for just a moment and just find out if there's any questions in the room, please.
So when you were naming factors on factor number 4, you mentioned poor modeling of health behaviors. And I'm wondering, so if you have in the middle where you have appropriate health behaviors and then you have poor health behaviors, what about if you go to the opposite end of the spectrum and you have excessive health behaviors, or excessive exercising, excessive doctor visits, or anything like that? Would that make a difference if you go to the opposite end of the spectrum?
So I'm going to repeat the question both for our listeners on the live webcast and also to make sure I understand it. So your question is in regards to factor number 4, which I was speaking about, poor modeling of health behaviors. What happens when that's at the opposite end of the continuum where there's extreme modeling of health behaviors? And am I understanding you correctly to say that sometimes that can go too far to the level of it being obsessive, or is it more that modeling of health behaviors can be a resilience factor?
Well, there's those past resilience factors where it goes excessive or almost abusive.
Right. That's what I thought you were asking. So when health focused can be actually to the point where it's abusive. No, don't eat that. That's not okay for you. No sugar in this household, right? No processed foods or so forth. And, that happens in Boulder. It happened in Portland too. Yeah. Yes, absolutely. And so there are times in which a parent can have their own actually OCD or excessive anxiety about contamination or vaccines, okay, yeah, or danger out there, right? We talked about overprotective mothers being a factor that's a derivative of the mother's own trauma, and I think that's a good example of that overprotection. Yeah, thank you. Am I answering your question correctly? Yeah. Okay. Or just addressing it. Good. Thank you. Any other questions at this point? Yes, please.
As far as just overall question, and I'm sure it's very good, but as far as the cause of PTSD versus adverse childhood events, or a recent returning veteran from Afghanistan, is when it comes to treatment, is the cause more or less important to how we'll treat than, or do most PTSD, regardless of ideology, can you pretty much silo both of treatment methods? 80%, whether it's adverse childhood, it's common veteran, whatever, are going to get 80%, fall into this type of treatment. Or is it just totally individualized connections or regulars?
Excellent question. So I'm going to repeat the question again, which is that if we're trying to differentiate treatment from, for example, a veteran coming back from Afghanistan versus an adult who experienced adverse childhood events, can we really kind of across the board make a blanket statement that a certain kind of treatment is better for one kind of trauma versus complex PTSD? And yes and no. I do think that the efficacy of something like EMDR or trauma-focused CBT for someone that has combat trauma but does not have underlying childhood trauma is actually going to be more effective. Because you're not going to bump up against the other barriers that would be interfering with treatment that come from the source of the kind of double whammy of both and. And for clients that, for example, just have complex PTSD, just have that, not just and to minimize, but have the adverse childhood events that are compounded and coming into adulthood, sometimes those trauma-focused interventions are not sufficient because there are so many other factors impacting personality and defenses and resistance or pre-verbal memories and so forth, and we'll get into more of that as we go. But I do think that working with someone that has more classic PTSD does not need as diverse an approach, and it doesn't take quite as long. So hopefully I'm speaking to your question well enough. Okay. Any other questions at this point? Okay. Yeah, please.
Could you speak a little bit more about distinguishing complex PTSD from BPD? How would you go about differentiating the two in your assessment?
Great. So distinguishing complex PTSD from from borderline personality disorder. And so how would we go about distinguishing those two? really, I would start with trying to understand, regardless, I would understand what is the trauma history. So you want to take a thorough trauma history, and we'll speak more about that as we go. And then we're also going to take a look at what are the symptoms. And if the current symptoms are involving rejection and abandonment anxiety, and self-harm and suicidality, in addition to the childhood trauma, then we might be looking at both, right? It's pretty unusual to have someone with borderline personality disorder that doesn't also have some childhood trauma, but that's not always the case, right? That is not always the case, and we understand that there are children who are born at greater susceptibility or risk for borderline personality disorder because of a degree of sensitivity of that child, but often we're also looking at the level of understanding of the parent and that child, so that attachment match. But primarily I would look at the symptoms, and if there are the additional symptoms that because not everyone with CPTSD have the urge for self-harm or carry suicidality or experience rejection as a primary distinguishing factor. Does that help? Yes. Okay, great. Thank you. Yes?
So on that similar diagnostic vein, what about differentiating the PTSD or CPTSD with dissociative symptoms like with DA?
Great. We are going to get there. So I'm actually going to just launch us a little bit forward here, because we're going to be speaking about dissociation here shortly, and we'll get into that. Good. So let's take a look now at some of the primary symptoms of complex PTSD. So again, this is mostly an overview. We're going to go into each of these 7 symptoms individually. So let's start by looking at intrusive symptoms. And here, the intrusive symptoms or re-experiencing symptoms, which often include flashbacks and nightmares, this is a symptom that also accompanies traditional PTSD, right? And but the intrusive symptoms from early childhood are often the experience of the pre-verbal memories. So these symptoms can come in the form of vague, uncomfortable sensations or pain or vague memories or little snippets of pieces. We're going to talk more about memory as we go, but I'm just going to kind of put a little plug here that it is not our job to fill in the gaps. Okay, we want to be very wise when we're working with pre-verbal memories, that we are not going to, in some way or another, provide a narrative for the client to those, or quote-unquote implant false memories, right? We can actually work with pre-verbal memories not having to know what happened, and we'll speak more about that. And there's also, in that category of intrusive symptoms, the hypervigilance, right? Being on guard, highly sensitized to your environment or people's body language. So a child that had to be watchful for which mommy am I going to get today, right? That vigilance, not just like the startle if the car backfires, but the vigilance of tracking your face, right? I've got one gal that I work with who will tell me, your face just changed. What are you thinking right now? Like she's so vigilantly tracking me. And at first it was a little off-putting, and then I realized, oh my gosh, this is how she has kept herself safe her whole life. And so to actually respond, how many of us got at some point trained that we have to be this kind of like neutral therapist and, like hold the blank face and all of that? Well, that doesn't work. That doesn't work for these folks, right? Like she wants me to be a human, and the more congruent I can be, the more transparent I can be. You know what? I am so sorry. I just totally got distracted, and I was thinking about this other thing. She'd go, okay. She didn't really care that I got distracted. She would care if I denied it, right? Or, wow, when you just told me that, it reminded me of this experience that I once had, and I just was really relating to you in that moment. Great. Say that again?
Does that mean
Validating, exactly. It's a validating of what they're noticing, which, if you can imagine, when this woman picked up on mommy's expression in her household, mommy, what, you look sad. I'm not sad. Or, I'm not angry, tell that to your face, right? So we want to be aware of how intrusive symptoms can actually take another form, and a very relational form here. It can show up in other senses as well. For example, a highly sensitized sense of smell. Right? Anyone work with clients who are super sensitized to smell? Yeah, you relate to that too. So, for example, the smell allowed them to know whether daddy was drinking. Right? Was there alcohol on his breath? Right? The smell in the home let them know it was. It's a bit like an animal, right? Who's highly trained to know, is this environment safe? Are there drugs going through the airport? Right? Like, what's happening? And so we want to respect the sensitivity that developed in order to protect them, and also recognize, and we'll talk about this as we go, that sometimes there can be these false alarms that go off due to that heightened sensitivity. So another primary symptom is emotional dysregulation. Right? And for asking this question about borderline personality, you're going to see a lot of crossover here. Overwhelming emotions that disrupt the ability for the client to function at work, at home, and relationship. High arousal, anxiety, rage, fear. Also, emotional dysregulation at the low arousal continuum. Helplessness, hopelessness, despair, depression. And to be able to ultimately, kind of be in the room with those extremes without burning out, right? Like that's the key, is that sometimes those big emotions get evoked in us because we've chosen to be in this field because we're empathic. Right? Because we're sensitive, because we care. And as a result, it puts us at greater risk of feeling all of this with our clients. That's big. And so our self-care becomes extremely important. Avoidance symptoms, right? Again, classic with PTSD. Avoiding situations, people, places that are reminders of the trauma. And how is avoidance maintained in complex PTSD, denying the past, repressing feelings, idealizing parents? I'll pause on that one for a moment. The idealization defense, because it's too frightening to realize that either I am in a home with parents who are so frightening or terrorizing or dangerous or gone, right, that I will resort to a fantasy. This is the magical thinking of the child, right? That either that is just not happening, or I can be the good adult. I once had a 3-year-old in my office, and he was more of an adult. I mean, he was in foster care at this point, but I was kind of blown away by how much the 3-year-old had learned to be the master regulator. And he would, sit down on the couch. He didn't play. He sat down on the couch like a little adult. And so there's a way in which a child will take over what was missing out there as a way to even get that need met for themselves. I'll take care of you, Mommy. I was working with a woman once. We'll actually talk about her case. She's the cases that I present are obviously well de-identified, but also I've been given permission to share these stories with you. And this woman had experienced domestic violence in her home, and she has a memory of being about 2.5 years old, and her father had attempted to choke her mother, and she was kind of curled up on the floor, and he had left the house. She went to the kitchen, poured her mother a bowl of soup, and brought it to her mother and sat down on the floor with her and tried to feed her mother soup, right? So this experience of taking over the parent role, right, as a way to avoid having to confront the fear inside of that. As a way to, we'll go down the list, to minimize the pain. And then as adults, maybe taking over using substances. I didn't ask who in here works with addictions counseling. Well, a lot of people, right? Right. That's another one. When you put the lens of addictions on there, you see it everywhere, right? Or emotional eating, right? These different ways to avoid having to feel, right? Excessive exercising, right? And dissociation. So we'll speak more about that here. So dissociation is a learned behavior that once helped the client survive and cope with a threatening environment. And from a biological standpoint, it is a built-in biological mechanism, and we're going to go, after our break this morning, we're going to spend some time talking about the neurobiology behind dissociation as well. But for now, we'll speak about this as a built-in biological protection mechanism that reduces the emotional and physical sense of the threat. Right? If I numb it out, if I go away, then it doesn't have to exist. Over time, dissociation can become a well-maintained division between the part of self that is involved with daily living or daily tasks and the part of self that's holding the trauma and the trauma-related material. So I typically think of dissociation as existing on a continuum, right? And the continuum can start out pretty subtle, right? Can be, talking about something and not feeling it. Can be driving down the road and thinking about someone else and not really having to think about your way to work, right? Be driving through a fog. Just kidding. But feeling foggy, feeling fuzzy, feeling tired. Pretty common symptoms of dissociation that are not all the way down at the end of the continuum of DID, but show up much more frequently in our office. And actually having the language to talk about the more subtle forms of dissociation with our clients becomes a very strong key to identifying when it's happening. And so that's my first line of assessment, is actually starting to talk about it and talk about dissociation not as like there's something really, really wrong with you if you learned how to dissociate, and people that dissociate have this other form of diagnoses in it, because it sounds really scary. Right? But actually, if we start to talk about dissociation as a normal protection to disconnect from something scary, and that if you grew up in a household where scary things happened, where bad things happened, it's pretty likely that you learned how to do this. And let's take a look at this together. And so we start to normalize it and talk about it, and then I start to hear a little bit more of like, oh yeah, I just thought I was crazy, but like I would just numb out, or I would start to have a hard time thinking. It was like all of a sudden my thoughts just went into this vacuum. Okay, let's explore that together, right? And so that experience of the disconnect, and we'll look at why this happens from a brain perspective, but the disconnect from the part of the brain that can verbalize, right, as part of a dissociative continuum. Feeling dizzy, feeling nauseous, right? It sits within a dissociative continuum. And now again, I like the look on your face, you're really studying this. It's like it sits in there, it becomes clues, because a big part of how we want to work as clinicians is within the window of tolerance. And we're going to talk more about that as we go. But to know what are the clues that someone might be leaving their window of tolerance and going into dysregulation or overwhelm or shutdown, we really want to know that and have that language in the room to be able to work through trauma safely. Okay? and a feeling of loss of control, of disorientation. And then we have our more extreme examples of a lack of distinction between the past and the present. But even that can be pretty subtle, right? Like there's a way in which, because the symptoms are still ongoing, there is a feeling that I'm not safe now, but I wasn't safe then. But actually in this room, if you look around, you are safe now. But the feeling confuses that. Right? The feeling of the chronic lack of safety that then fuels the symptoms. And then also lapses of memory or lost time. And in its most extreme form, multiple parts and subpersonalities. Okay. We will talk more about the differential diagnosis as we go. What I will say kind of on the short end right now is that the use of certain instruments like the dissociative experiences scale, or in more complex cases, the MID, the multi-axis inventory for dissociation, can be really helpful for differential diagnosis, and those we'll come back to as we go forward. So our fifth category of symptoms are interpersonal problems. Here, these are patterns learned within the early attachment experience that tend to get repeated in adulthood until new and effective interpersonal strategies are developed. So clients might withdraw or blame or push away or criticize. They might do that externally in their relationships outside and struggle. They might come in and say, well, you know, I ended my relationship with Jimmy 3 months ago, and now I'm dating Danny, and it's the same relationship, right? And so we can start to look at why are those repeated patterns happening, and what is it that's really getting repeated? Where is the source or the origin of that learned that learned pattern of this is what's familiar, therefore I keep going toward the same thing? And those repeated dynamics happen with us. Right? And so we're in the room and they evoke in us the urge to want to push them away, for example. And we want to be wise to catch the evoked experience as a way of understanding the client's inner world and their inner kind of blueprint of relationship that's going to show up in the room. And we'll speak more about that as we go as well. Our sixth category of symptoms are cognitive distortions. Here, the inaccurate beliefs about oneself and others in the world. Something wrong with me, I'm so stupid, I can't seem to do anything right, it's all my fault, I don't deserve to exist, I'm unworthy, I can't trust anyone. Right? And with this becomes a compromised meaning-making system. So I'll give an example here. This is a woman who was told that she wasn't wanted as a child, had multiple repeated experiences of rejection, of feeling that she was kind of pitted as the kind of like a Cinderella syndrome in her family, very much kind of took over the role of taking care of everyone, but just because she just happened to be there, but not really cared for or loved in her family. So she carried this belief that she shouldn't exist. And at one point in her adulthood, she had experienced a car accident where she nearly died, and she used that experience as a way to confirm the underlying belief. See, I really shouldn't be here, right? So this feeling of being a mistake became her way of interpreting other life events. And we'll talk more about how we unwind that as we go. This is a really important category, and you were mentioning the ACE factors, the adverse childhood experiences, and this is going to tie into that, is that what we understand is that complex PTSD is connected to health problems, right? And this is a very hard to treat interaction, because the experience of chronic pain or chronic illness and pain conditions. So people will come in experiencing either epileptic or non-epileptic seizures, a conversion disorder of seizure-like symptoms, or migraines, or gastrointestinal problems, autoimmune disorders that get kicked off by adverse childhood experiences, fibromyalgia, chronic fatigue, and other medically unexplained symptoms. Even sometimes chronic Lyme can have a real strong connection to underlying unaddressed childhood trauma. And so, the biggest piece that I want to name here on the front end, and we'll spend more time talking about this, is how important it is to have compassion for these types of symptoms, right? It is incredibly painful and draining and feels helpless, and clients blame themselves, and so we just want to really hold this with so much depth of understanding. Please. Yes.
Oh, Lyme disease.
Yes, Lyme's disease. Yes, yeah, thank you. Yep, good. So, the ACE study, for those of you, I'm going to guess that a lot of people in the room are familiar with this one, so I won't spend a ton of time on it, but if you are new to this, this will give you a base to launch out from, and it's really worthwhile knowing that the Adverse Childhood Experiences study took place at Kaiser, and they assessed 17,000 Kaiser Permanente patients with self-reports of childhood events. A little bit about the origin of the study is that Felitti had been doing research on obesity, that he had a client that had come in who had lost all of this weight. She put the weight back on, and he got curious, and he said, well, how come you put the weight back on? And she said it was too threatening to have that weight off, and she started to talk about her experience of childhood sexual abuse. And it just clicked something off for him, where he went, well, I wonder how many more people this might be true for. And he wanted to understand the connection between obesity and childhood trauma. And so this study became this launching point, and it opened up so much more, particularly this undeniable correlation between childhood events with physical and mental health problems into adulthood. So the ACE study looks at 10 categories. This is in Appendix A because there were a few slides. There was just a little too much information to get it into a small box. And but these are physical and verbal and sexual abuse, emotional and physical neglect, domestic violence, household member who abused substances, household member with mental illness who was imprisoned, and when parents were divorced. The results show that 4 or more ACE factors is a kind of critical mass of stress that increases the risk for alcoholism, cancer, suicide attempts, obesity, drug abuse, heart disease, smoking, physical inactivity, which increases risk for other things, skeletal fracture, lung disease, liver disease, depression. This went way beyond the original obesity study. Right? And the one more piece to name here is that one ACE factor was predictive of having more ACE factors, right? And that 4 ACEs led someone to be 4 times more likely to be depressed, 7 times more likely to use substances, going back to our addictions comment, 12 times more likely to attempt suicide at some point in their lives as compared to individuals with an ACE score of 0. And of course, at greater risk for all of these physical illnesses and conditions. Thankfully, we also recognize that resilience factors offset ACEs. So, resilience factors, the belief that your mother loved you as a child, belief that father loved you, having other relatives who cared for you, having neighbors, friends, teachers, coaches, and having someone who cared how you did at school, having clear rules in your household that you could follow, someone to trust that you trusted to talk to when you needed, right? That might be you for some of your clients, right? Having people who saw you as capable, being independent and a go-getter, and believing that life is what you make of it, right? So, going back to Donald Meichenbaum, he says that we are always listening for the golden nugget of a client's resilience. And sometimes that comes in unusual forms like street smarts, right? Or stubbornness, the ability to reach out for help. And I'll share a brief example here. This was a woman who was born into a family with an alcoholic father, with a mother who not only didn't want her, but also was not wanted herself. She had been abused by her father. The mother had been abused by the client's grandfather. And at some point when the client was about 4 years old, the mother said, "I can't do this anymore," and she sent the client to go live with the grandparents, the grandfather who had abused her, right? I mean, so it was very compounded layers. At some point, the grandparents said, "Well, we don't want to do this again. We'll send her to foster care," and so then she got sent back to this family. And so her mother really in all was rather mentally ill. She was angry, she was rejecting, she smoked, she was verbally abusive. So this, eventually the parents divorced. The client's ACE score was 5. She had experienced verbal abuse, emotional neglect, a parent who was mentally ill, parents who abused substances, and her parents got divorced, right? And she learned at a young age, however, that the neighbor was really nice. Really nice, like not bad nice. Really a nice neighbor, a woman who actually worked for social services. And she would go over to the neighbor's house for milk and cookies, and she started to talk to her neighbor about what it was like in her house. And so by the time she was 12, the neighbor had actually been able to get some financial support and sent her off to a boarding school. The boarding school was a very positive experience for her. It was much safer. It had its own quirkiness, right? But was much safer than her household and much more predictable. So yes, the first 12 years of her life were pretty much hell, excuse the language, but it was very, very difficult. And she had this ability to reach that produced a very positive result. And what is so touching, and I still work with this individual today, is that capacity to reach and to identify who are the good people out there is still something that's inside of her, that resilience factor was so profoundly offsetting of her 5 ACEs. And that she has been able to really create a relatively positive life for herself. Yeah. So here's a little bit of a kind of self-inquiry moment. And you can do this at home if you're watching via the webcast, and I'm going to invite you all to do this here. And but I'll kind of start by just naming this quote. Did any of you in the room see the Mr. Rogers movie? Have you guys watched it yet? If you haven't, please do. It is so touching. You will have a new internal good ally, I think, in Mr. Rogers. And but what he said, and this quote actually went viral after the Boston Marathon, is that when I was a boy, I would see scary things in the news. My mother would say to me, "Look for the helpers. You will always find people who are helping." To this day, especially in times of disaster, I remember my mother's words, and I am always comforted by realizing that there are still so many helpers, so many caring people in the world. Okay. So take a moment here to look over these questions, to review the list of the adverse childhood experiences, and to identify what is your own ACE score. I would also invite you to look at the list of the resilience factors, also found in the Appendix A if you want it there. And what were the resilience factors that you had as a child? What has helped you navigate the narrows of your own childhood? And I'll pause here for a few moments as you can take some time to reflect on that. Ron, can I ask you a question?
Yes.
I was going to break at 9:45. Is there a rigid webcast time to break, or we can just break when I need to break? Okay. Perfect. Okay, I like that. So we'll come back with a little bit more time for reflection. I want to cover a few more slides, and then we'll actually do a little bit more introspection before we take our break. So the next piece that I want to speak to here is some of the additional symptoms of complex PTSD. And again, we're going to see some crossover with some of the other possible diagnoses. But additional symptoms would be self-harm, suicidal thoughts, plans, or attempts, addictions, emotional eating, eating disorders, social anxiety, difficulty concentrating, impulsivity, and excessive risk-taking. And we could probably even go further and add others, but we'll stop there for now. What this points out is that the realities of working with complex PTSD is that it can evoke feelings in us as clinicians of helplessness, hopelessness, and despair, isolation, loneliness, injustice and unfairness, suffering, rage, and evil. I don't know if anyone in here has watched this, and I watched it, and it's a pretty hard watch, but it was also worthwhile. You know the story of Elizabeth Smart, who had been abducted. Yeah, she is now doing public speaking about her experience and what has allowed her to survive that and overcome it and come through it. Has anyone seen this? Yeah, it's powerful. And what she shared in there is that when she was rescued, that her mother said to her, the most powerful thing that you can do that can help you get through this and get through the evil of what these people did to you is to live a life that does not let them take your happiness from you. Right? And to show them that you can still live a happy life. And she spoke to the power of those words and how she was able to confront that and still move forward and live her life. And you know what she went through in that 9 months and what was stolen from her at the age of 14 for 9 months of her life was tremendous. And I think it is so powerful to really hear for our clients or help them discover their own meaning making that ultimately helps them come through and overcome and rise back up from things that are sometimes unspeakable. And the other piece for us to hold is that for us as therapists, the realities of working with these kinds of states is that sometimes those states can be induced in us. Right? Like we're sitting with someone who is experiencing so much hopelessness and despair and is telling you how they don't want to live anymore and there's nothing worth living for in their life. And at some point you sit with them and you go, gosh, I can't think of anything that's worth living for in their life. right? Like it gets so powerful. Bill O'Hanlon talks about this in the way that we can get hypnotized by the client, and that our job is really to stay differentiated from that state, not to lose compassion for it, but to not get kind of sucked into the vortex of it, right? So the next little exercise that we'll do for about 8 minutes or so, 5 minutes or so, is to reflect on these questions for yourself. And you can write some answers to these questions. I will also invite you afterwards to pair up as dyads and to talk about this for just a few minutes if you'd like. And so, or triads or whatever, just small groups. Okay. So the first question is, as therapists, we must attend to our own wounds, hence your own ACE factors, right? Or they will contribute to your own blind spots in your work, right? Second question is, what resources help you stay present with your clients as they experience helplessness, despair, suffering, and so forth? What meaning-making, spiritual perspectives, or self-care practices help you attend to the weight of this, to the weight of trauma processing with your clients, the weight of this work? Okay. What support do you have to work with your own countertransference when it arises? And what additional support do you need? So take a few minutes on your own, and then I'll cue you to partner up with someone or a few people. And if you're at home, you can write about this on your own there. All right. So you won't be able to speak about all of this with each other, but as you come back together, maybe pick someone sitting by you to speak about some of these questions, or one of these questions even that spoke to you, and we'll just take a few minutes in that way. You too? Okay. So I know there's a lot to talk about here. What really impresses me is how much there is to talk about here and how kind of willing you were to kind of dive in and engage in that conversation. We'll take a break here in just a few moments, but before we take a break, does anyone want to share anything about kind of what stood out for you in that exchange, in your own inquiry, or what maybe you've learned through this process thus far, or any lingering questions that we've got before we break? Really? We're all ready. Good. We'll take one before we break. Yeah.
So I graduated fairly recently from grad school, so I'm working within my first job. So the last year has been kind of a journey of self-discovery, not just in terms of so who am I as a clinician, but also understanding what's happening in my own personal experiences. And a lot of it has been really eye-opening in terms of kind of getting an understanding, like seeing things in clients and then seeing like, this happened to me. Like,
Yes.
How so having, at least for me, what I think one of the most important things has just been having being very purposeful about a clear boundary and separation.
Yeah.
Because at least the last thing that kind of want to happen is to override someone's experiences with your own in the middle of the second.
Yes. Yes.
Which is something that I think we're really, especially working with trauma, is we're at pretty high risk of happening.
Yes, yes, thank you. I so appreciate what you're sharing about how, I think this is often the case that when we enter this field and we start to learn about the work that we're going to do with the clients, and then we're like, well, wait a second, this is my work too. And that, as I mentioned before, not only do many of us choose this work because we're sensitive and empathic and caring, but also many of us choose this work for our own healing journey, and that it's very connected to our own experience or what we've already had to overcome or what we're still overcoming, and that fuels why we choose to be in this field. And I think the more that we recognize it, the less likely it's going to, in some way or another, kind of roll over or steamroll or play out unconsciously in our work, that the more that we can own it. And that's really why I start this inquiry process right here, which is, clinician, know thyself, clinician, heal thyself, physician, heal thyself, right? That when we can start here at home and know not only what is our own background, what are our strengths, what are our susceptibilities, all our vulnerabilities, so that, again, we can create a sustainable approach to this work where we're less